Now I'd like to introduce our speakers, and we're so thrilled to have them today. One of our care coordinators let us know about them. They are Doctors Michael and Daniel Devine. They completed their fellowships at Johns Hopkins School of Medicine and Harvard Medical School, respectively. They founded their dream practice, Divine Concierge Medicine, which offers around the clock access and guaranteed same-day appointments. So not only will they speak to us about heart disease today, but I know many of you have questions about concierge medicine, so they'll talk to us about that model as well. And now I'll hand it over to them. Thank you for being here.
All right, thank you so much, and thank you to everyone for coming today. We do appreciate you, and we look forward to getting started. So first slide here, just as a basic introduction, heart disease is what we'll be talking about primarily, but I would like to start maybe just by chatting a little bit about us, our practice, our background, just to give some context to how we look at things clinically, and maybe give some relevance to some of what we're talking about later in the presentation. Okay. Just reiterate some of that, what we'll be talking about. So as I alluded to, Dan and I are both double board certified in internal medicine and geriatric medicine. I did train at Johns Hopkins and Dan at Harvard Medical School, Massachusetts General Hospital. So we've been very privileged to train with some of the very top minds in the field. We like to bring what we've learned and experienced at these fabulous institutions back home here to the Philadelphia area, which is where we're from, and offer all of that to our clients. The basic idea of our practice, the guiding light, was being able to offer primary care exactly the way that it should be. Too often these days, there are compromises that are made in order to try to increase the efficiencies of care, not for the patient, but for the doctor, because there are more patients that need to be seen every day than the doctor has time for. We try to turn those tables back around to the way that everything started. If people need help, it's our role as the physician to be able to take care of them, not the other way around. This is a pretty familiar scene here, waiting in a waiting room, people getting frustrated, the doctor perpetually being behind schedule. It's a very frustrating experience. And fortunately, there is a solution, which is concierge medicine. And a lot of what we get at in terms of some of these sore points, your doctor not knowing you, prescribing medications because it's an easy solution, not being accessible over the phone to answer a question in between visits, not being accessible when you are sick. These are really painful points in the healthcare system that, again, concierge medicine does try to aim at specifically to try to smooth over for patients. This is where the problem starts. Unfortunately, the healthcare system is broad and extremely chaotic. You may notice all the way down in the right lower portion of your screen, you see the patient bubble. That's you. But everything else around you, everyone who's making decisions, are some other part of this web. And it is so convoluted that one end does not know what the other is doing. And that's part of the explanation as to why things have become so complicated. But that's our role, to be able to simplify this for you in terms of concierge medicine and what it is we're offering. So concierge medicine is a solution. It allows us to deliver exactly the type of primary care that you would imagine having in an ideal situation. It's the type of primary care we like to say our patients deserve. It allows us to spend all the time that we need whenever a patient needs it, without making them jump through all the hoops that are kind of baked into the normal system and the way things exist. In terms of who can benefit from concierge medicine, in our opinion, everybody. We are all depreciating assets, if you want to think about it in that sense. And if it's not managed properly, being the body, our life, our health, we do put ourselves at risk in terms of our longevity as well as our overall well-being. This is kind of a simple quote here that kind of encapsulates what it is that we do. Our role as doctors in concierge medicine and in primary care, broadly speaking, is to ensure that our members receive the right information at the right time so they can make the right decisions and live long, healthy lives, which is our goal. Our philosophy may be relatively simple, but it does make a tremendous difference in terms of the impact that it has for our clients. It's more about the intangibles than it is actually saying, oh, you've got a beautiful office that looks like a spa. It's more about the time, the access, the personal attention. It's about us being able to long-term strategically plan with our patients and continually execute upon that plan. It's about what matters to you as a patient more than what's just the matter with you. And it's about us thinking about our patients' health, even maybe when they're not. You don't have to worry about things being missed. We do custom tailor the experience to everybody's needs. No two people are coming from the same place. They don't share necessarily the same goals or have the same challenges. So we use things like the fact that biology is predictable to our advantage to be able to custom tailor those care plans. And getting an understanding of what our patient's personal risk is, understanding what their goals and tolerances are, it helps us come up with a custom tailored plan for everyone. The only downside of concierge medicine, the way that I see it at least, is the fact that it does require a doctor to take significantly fewer patients. So space is limited. It's the only way we can make sure that we do have the time and the access that our patients need and desire. This does allow us to deliver upon that experience, exceptionally so, and it does make a big impact. And the other downside, I suppose, would be that it is a cost out of pocket. So one of the hallmarks of concierge medicine or direct pay medicine, whatever you would like to call it, is that insurance does not cover these practices in terms of membership costs. But I would encourage you to think about the cost, not just in terms of dollars, but in terms of the value that it provides. We always say that if you could actually equate this value to quality of life years and peace of mind, what is that worth? For a lot of people, it's worth a tremendous amount, far more than what we charge. We do try to be reasonable, and if anybody is interested in chatting a little bit more specifically about our practice, we'd be happy to do that and discuss membership and what that entails. But just to kind of wrap all that up, Dan and I are affiliated with Jefferson, Penn, and Mainline Health Systems. This is just kind of a brief summary of what we had talked about in terms of what we offer as a practice. All right, without further ado, just one last closing quote, and we'll get right to the piecemeal of the conversation here. When you have your health, you have many problems. When you don't have your health, you have but one problem. And I think that really encapsulates the entire sentiment of why concierge medicine is important. All right, Dan, I will turn it over to you.
Thank you, Mike. So the main topic of our conversation today is heart disease, and we use a lot of different nomenclatures in medicine, a lot of synonyms: cardiovascular heart disease, heart attacks, ASCVD. ASCVD stands for atherosclerotic cardiovascular disease, and this is actually describing what's going on in the heart. I think it's important to start this out with a little anatomy lesson of what we're actually looking at, and it'll help us really dive into what's going on in the body at a molecular level. On the right side of our screen, we have a visualization of the heart. Those red lines, the coronary arteries, are the main blood vessels that supply the heart muscle with blood. The heart needs a tremendous amount of fresh blood, freshly oxygenated blood, to be able to continue pumping and squeezing and delivering blood throughout the body. To the far right side of the screen, we see a transsectional cut of a blood vessel. And you'll notice that this blood vessel is narrowed with this yellow narrowing. That's a cholesterol plaque, and that's really what we're going to be diving into. I think we can go to the next slide. Why do we care about heart disease? Well, first and foremost, it's the leading cause of death amongst Americans. The pie graph in the middle of the page is for men, and it shows that 1 in 4 men will ultimately succumb to heart disease. And on the upper right portion of the screen, we'll find that 1 in 5 women will ultimately succumb to heart disease. This is why we care so much about it, and why so much research, medications, and time has been dedicated to trying to solve this problem for us. So what causes ASCVD? And it's a great picture. The biggest things that lead to ASCVD are risk factors, controllable risk factors. The 4 big ones are smoking, blood pressure control, cholesterol control, in what we call the metabolic syndrome. And I realize metabolic syndrome may sound like a new word to some, but we think of conditions like diabetes and prediabetes and polycystic ovarian syndrome as conditions that lead to increased inflammation in the body, which is the metabolic syndrome. And all of this creates more inflammation, which creates more cholesterol plaque deposits, which leads to increased ASCVD. So where does cholesterol come from? Most of us immediately think to this nice burger from Five Guys or Shake Shack as being the source of all of our cholesterol and all of our problems. And this is a real fallacy in popular culture that if we just clean up our diet, our cholesterol is going to be okay. Next slide, Michael. Realistically, only about 20% of our cholesterol comes from our diet. The other 80%, the lion's share of our cholesterol, is actually made by our liver endogenously. In this diagram, you'll see this brown part in the upper left portion of this picture is the liver. The liver is a very, very important organ in the body. And in cholesterol manufacturing, it's essential. This is where our body creates all the different cholesterol particles that circulate. Cholesterol is not a bad guy. It's what our body needs. Cholesterol particles are used in cell membranes, in neurogeneration, in energy production. The problem is sometimes cholesterol can inappropriately get deposited in arterial walls. And that's actually the pathology of this. So the ultimate question, is cholesterol all just the same cholesterol? What it comes down to, what we found is that it doesn't matter if you have a lot of cholesterol, it matters how that cholesterol is packaged. The packaging, the proteins surrounding the cholesterol molecule are what's going to dictate whether that cholesterol is absorbed by a muscle cell to be used as energy, or it's going to find its way into that blood vessel wall and become a problem for us later in life. So the key here is how the cholesterol is transported, not necessarily what the cholesterol is in and of itself.
So those are the lipoprotein particles that we'll be referring to. And it's important to understand this. It does get a little sciencey, and I apologize for that, but we do have to get into the weeds just a little bit so that way we know what we're talking about when we're talking about how to monitor this and how to manage it. So you can kind of imagine cholesterol, it's essentially fat. It's like oil, and the blood is very liquidy like water, and they don't mix. So you can't just circulate naked cholesterol in your bloodstream. It has to be packaged. And it is the type of package that dictates whether or not that cholesterol is going to be acting bad or it's going to be beneficial. To use things like hormone synthesis in the body or for energy production in your muscle cells. And this here is kind of a microscopic picture of what these things may look like. They essentially are bubbles, and the shell on them is made of proteins and different types of fats to keep the cholesterol nice and insulated on the inside, and the outside, obviously being able to freely flow throughout the bloodstream. This may look somewhat familiar. This is a pretty standard looking cholesterol panel that your doctor may have ordered for you somewhere along the way. And you may have heard things like good cholesterol and bad cholesterol, and maybe the respective LDL or HDLs may sound somewhat familiar to you. It's kind of true to think about these things in that way. But the real thing to know here is that what we are talking about in terms of these different types isn't the cholesterol itself. All of the cholesterol is the same in these, but LDL is a type of cholesterol particle. It's a lipoprotein particle, as is HDL. And the shells are different, which means that they behave differently in the body. Some of which, like the LDLs, are much higher risk for driving plaque development, the process of ASCVD, cardiovascular disease, whereas HDLs may be beneficial. So just looking at this as a whole again, the important take home from this slide here is just recognizing that even on your cholesterol panel that you're used to looking at, it tells you more information about the types of cholesterol than it does necessarily, about the types of cholesterol packages rather than the types of cholesterol itself. The downside of this type of a panel, and the reason we need to dive a little bit further than this, is because it doesn't necessarily tell us about the number of particles that you've got circulating. So if we were to look at LDL, the bad type of cholesterol, and you had a very high number there, that would only tell me that the amount of cholesterol in all of your LDL particles was high, not that you had a large number of particles. And you could even break that down further. If you had two people and both of them had a very high level of LDL, and those levels were the same. Let's just say it's 180. One person may have very large LDL particles. And because of that, to carry that cholesterol load of 180, it needs fewer of them because each particle can hold more. The other person may have very tiny, and this is all genetic, very tiny LDL particles. And because of that, it needs more particles to be able to carry that LDL cholesterol load. The person with the larger number of particles, even though they're smaller, is at significantly higher risk of making cardiovascular plaques. So unfortunately, this standard cholesterol panel doesn't tell us about the number of particles, but we can use some understandings of biology to be able to tell the difference. So just a basic recap here, just to kind of visualize what we're talking about. The generally good types of particles are your HDLs. The bad types of particles are things like LDL primarily, as well as some other things that exist in very short periods of time, like ILDLs and very low density lipids, VLDLs, chylomicron remnants, etc. The biology piece here that we can use to our advantage is that the shell of that lipoprotein particle does have something we can measure called an apolipoprotein B. It's only present in one copy and only present in the bad types of cholesterol. So if we measure an apolipoprotein B level, which we could do with a simple blood test, we can now use that as a proxy to understand the number of bad particles you got circulating. So just diving in now into the actual mechanics of what's going on, assuming that you've got LDL circulating in your bloodstream. This is what a healthy blood vessel looks like if we were to cut it in half lengthwise. So you have these tiny little globules here, and I hope you can see my mouse because I am pointing to them. These are what we call epithelial cells. This is what creates the inner lining of your blood vessels. The red area here in between those two layers of epithelial cells is your blood. And then now above and below those epithelial cells, we have the muscular lining of the arterial walls. So again, this is just a normal blood vessel that's been sliced in half. This slide here gets into trying to demonstrate some of the pathology. So these bubbles with the black squiggly lines circulating in the middle here where the bloodstream is, those are your cholesterol particles. Those are LDL particles. And that black squiggly line is trying to represent their LDLs because that's an apolipoprotein B that we're measuring. Now, what happens is these particles can get in between your epithelial cells and enter the actual blood vessel wall in the muscle layer. And once it gets in there, it can create loads of inflammation. And that causes the body to get reactive. It actually starts to almost create a scab over that really inflamed, oxidized plaque that's forming. And that plaque can get thicker and thicker, and it could actually start to cause a narrowing in the blood vessel. And that's a problem because it predisposes you to having a heart attack. But it's important to understand that a heart attack very rarely happens because these plaques gradually get tighter and tighter. What happens in the setting of a heart attack is you have these thick plaques, and then suddenly a piece breaks off. We call that an acute plaque rupture. And that process is where actually you get a tremendous amount of inflammation that creates an actual clot that then completely blocks the blood flow downstream of that blood vessel where that happened. Now, when you're blocking blood flow, the muscle that's dependent on that blood flow for oxygen and nutrients is now getting the supply that it needs. And as that muscle starts to die as a result, that is the heart attack, and that is the pathology of a heart attack. So that's why it's important to make sure that we are reducing the number of plaques. And in order for us to reduce the number of plaques, I mean reducing the number of bad particles circulating that drive plaque development to reduce the risk of heart attack.
So now that we have some understanding of what ASCVD actually is and what's occurring in the body, how do we check for this? How do you know today that this is occurring in your body? The first test that we like to use in our clients, in addition to laboratory testing, we'll check blood tests for cholesterol panels, et cetera. We'll go into that a little bit later. But we use some advanced imaging testing that's been around for about 15 to 20 years. The first test is called a coronary calcium score. This is a non-contrast enhanced CT. The entire test takes about 10 minutes to perform. Cardiologists have been using this, as I said, for the better part of 2 decades. Insurance does not cover this study. In most of the health systems, Penn and Jefferson and Mainline, it's about $100 to $130 for this test. This test gives us a wealth of information. On the left side of the screen, what we're looking at is a cross-section of the body on a CAT scan. So if you imagine you were cut across the chest, right in the center, what that yellow line is pointing to, that arrow, is your heart. And that bright white in the middle is calcium. That calcium is within a coronary artery. If we look on the bottom of the photo, right there on the left side, we can see the bone of the vertebrae, which is also white because bones have calcium. We should not be seeing calcium in our coronary arteries. This individual in this study clearly has an elevated calcium score. What we find is when folks have plaques developing in their arteries, over time, those plaques will become calcified. This is a process that occurs in the timescale of years, not overnight. So what this test is helpful for when we get in an individual, it doesn't matter whether they're 40, 50, 80, or 90 years old, it tells us that there's been a process occurring in the body and that they do have elevated cholesterol deposition into their artery walls. So this test, what we look for is a score of 0 or more than 0. So some folks have a score of 2,000, others have a score of 50. All that tells us is that those folks have calcified plaque deposition. The individuals that have elevated cholesterol, we get this study and they have a score of 0, they're at much less risk for developing a heart attack later in life. But if your score is anything but 0, it begs for further analysis and further workup. A more advanced test, and this is a test that's often covered by insurance, usually with the help of a cardiologist, is a coronary calcium angiography test, the CT coronary angiography. This is a dedicated CAT scan that uses IV contrast to light up the blood vessels. What we see on the left side of the screen, the first of these 3 pictures, is what we call the left anterior descending artery. This is the main coronary artery supplying the heart with blood. You can see where that yellow arrow is on the left side of the screen and narrowing. And what we can't tell based on that narrowing is what's the morphology of that plaque, or what does that plaque actually look like? The middle picture, as we see, where the yellow arrows, the yellow lines are in the middle of the screen, we see a narrowing of that blood vessel. As we travel north or up to towards the top of the screen, we see white narrowings. Those white narrowings are calcified plaques. Those are probably more stable. The chances of a calcified plaque rupturing and causing an acute heart attack are significantly lower than a fresh new plaque that's not calcified and solidified. So we'd worry on that middle portion, that middle picture, those yellow lines are signifying a new plaque that may be at risk for rupture. Whereas on the right side of the screen, the yellow lines are indicating a calcified old plaque. So what you can see is the coronary calcium score gives us a very rough idea. Do you have plaques present or not? We would use a coronary angiography test to show what do those plaques actually look like, and are those plaques at risk for rupturing? We can even take this testing a step further. This slide demonstrates an artificial intelligence assisted coronary angiography test called the Cleary model. And this is using artificial intelligence to review thousands of images from a coronary angiography study to actually show what's the morphology. Is that plaque a nice little hill, or does it look like a peduncle, something that's really hanging off that could just flick off and break off and cause a heart attack? What this does is it makes it very easy to get these studies and to get them interpreted quickly. If a cardiologist was sitting in front of a screen reading thousands of images, it may take them hours to put together the story that Cleary would put together in minutes. So this is bringing coronary angiography to more people.
So if we get these tests, if you're a patient, we get these tests, we know your cholesterol side. We take it a step further. We now know that cholesterol has deposited in the walls of your blood vessels and you do have coronary artery disease. What do we do about that? Is there anything to do? Fortunately, yes. It's a combination of lifestyle modifications that we do recommend. If we do have the capacity based on your ability to diet and exercise, weight loss is tremendously helpful, but also getting control of the other risk factors, making sure that you're not smoking, making sure that your blood pressure is not too high, and making sure that your apolipoprotein B level is as low as possible, which is essentially effectively lowering the number of bad particles you've got circulating, because we don't want those to deposit themselves into the walls and create even worsening of the plaque development that you've got. It's really important to make sure that if you do have high blood pressure, high cholesterol, if you have a history of smoking, if you're overweight, if you have diabetes, that you are surveillanced properly and periodically. It's not a one and done situation because this is an evolving process. ASCVD is not a disease where you do something bad to yourself and then you get a negative response a day or two later. It's a disease with a very long runway. It requires sometimes decades before you actually start to see the ramifications of some of these processes at play. And the earlier you catch it, the better you are, because we could actually make changes before things reach critical mass. This page here just kind of reiterates what we had talked about to try to pull it all together. So this is the conversation that you would hopefully be having with your doctor about the types of things to be talking about, knowing in terms of surveillancing to make sure we know exactly what's going on. So the first few are all blood tests. That's the apolipoprotein B. LP little a, we didn't really necessarily touch upon earlier on in the talk, but it is another important type of lipoprotein to know, because the LDL particles that not only have an apolipoprotein B, but also have a lipoprotein little a, are extremely atherogenic, meaning they are going to actually cause higher risks of coronary disease that are magnitudes larger. And the LP little a is something that is almost entirely genetically driven. So about 20% of people, about 1 in 5 in the population, are going to have the genetic predisposition to making lots of LP little a. And it's important that you get this test checked at least once to know if you're one of those people, because not everybody likes to be on medications, particularly statins, which we use to treat cholesterol levels. And if you did not have a high risk, say, hypothetically, you're 75 years old, you don't have an LP little a that's elevated, your cholesterol and your ApoB are elevated, but we get a coronary calcium score and it's 0. Well, you have a little bit of wiggle room there to make the decision about maybe not doing treatments. Contrarily, if you're that same person, but you are LP little a positive, and we get that coronary calcium score and it's well over 1,000, that lets us know that you're in trouble. And we better start taking every measure we can to reduce your risk, making sure that you're on the right types of medications and taking the right types of lifestyle changes to make sure that we're reducing the risk of heart attack for you long term. And this just reiterates that it's not all about medication. Dan and I are allopathically, classically trained physicians, but we always include as part of the conversation non-medicinal treatments for our patients. So are there things like fish oil, omega-3 fatty acids that are beneficial? Are there other types of things that you should be eating or avoiding, for that matter, that could be contributing, knowing that we're only going to be able to move the needle a certain amount with these sorts of things? And just counseling our patients on these sorts of behaviors is going to be really important to the overall holistic picture of the management of this disease process. So just a quick review of some references here. And I think at this point, we could probably open up the floor to any questions.
Great, thank you. I got some sent directly to me and then some in the chat here. So let's start with the ones that were sent directly to me. This person is saying that they know that there's research saying that if you've been taking statins before you reach 80, you should keep taking them. But what about people who are over 80 starting to take statins?
So what we're getting at here is the research that's looking at 10-year risk. A lot of the research when you're looking at heart medications are looking at what is the 10-year risk of a heart attack. And when you already have somebody who's lived beyond the life expectancy of 72 to 76 years, are we really going to improve upon their overall condition by trying to reduce their 10-year risk? And this is a moving target because it really is not the same for everyone, and it's changing over time because someone may have the capacity to live to 100 years. Other people who are going to be 60 years old and near the end of their life. And determining this case by case, you're 80 years old, but you may have 10 or 20 quality life years left. That would be a person that I would say, even though you're 80, probably should start a statin if they need one. Contrarily, if you have, let's say, active cancer, and you know that your life expectancy has been significantly blunted, are you going to stand the benefit of being on a statin medication? Most likely not. In those cases, we could collectively decide not to use treatments like this.
And you also look at someone holistically. Were they a smoker earlier in life? What's their family history in terms of stroke predilection? Because when you think about statins, it's not just to lower the cholesterol. There's been a lot of research in neurology to show that statins help stabilize plaques. So it reduces the frequency of those plaques flicking off and causing an event, either a heart attack in the heart or a stroke in the brain. So there's a lot that goes into that conversation. We feel very strongly that medicine's gone in the wrong direction of painting with a broad brush and trying to make population level changes for everyone when medicine's so nuanced, and it truly is an art as much as a science. And we really need to be looking at everyone's individual risk and what their goals are for the next 10 years. If you're 80, but you still like to golf, you like to travel with your friends, why are we putting barriers on you? So a lot of that's really individualized.
Yeah, thank you. What's the research on statins and dementia?
So the process of dementia is kind of complicated because dementia is an umbrella term that doesn't necessarily describe the individual pathology that happens. With that said, the vast majority of dementia syndromes, particularly vascular dementia, which is a blood vessel disease, and even more recent research looking at Alzheimer's types of dementia, and those two types probably constitute about 90% of all dementia diagnoses. It does make sense to take care of blood vessels in the brain the same way we do for the heart. So we have the same levers to pull. Lifestyle, we want to make sure that you're not overweight and that you're not smoking. We want to make sure that the insulin resistance or blood sugar control in your body is kept in check. And we want to make sure the blood pressure is also well controlled. And the types of bad cholesterol particles are as low as possible to reduce the plaque development. Because it's the brain starving for blood supply and those two types of dementia processes that leads to the detrimental effects downstream where people actually lose their capacity to function.
And what I'll add to that as well is there was a lot of research, particularly out of Europe in the 2010s. It was very anti-statin. There's a lot of myalgias and muscle aches associated with them. Were they really even helpful? And a lot of us, and I was actually involved in some of this research on deprescribing statins, and we took a lot of people off of these medications. And what they found in the preceding years afterwards was a much higher incidence of stroke and TIA, which greatly diminishes quality of life. So the pendulum's actually swung back to using statins more frequently now. But the really exciting news is that statins, even though they're a gold standard for cholesterol management, there's better medicines on the market now. The PCSK9 inhibitors, like Repatha, are a really common one. There's a tremendous number of drugs in the pharmacologic pipeline right now to treat cholesterol that are non-statin based, but still have the same great effects. So we're not going to just be pigeonholing ourselves in the statins per se. There's ways to work around this, but not something that we should ignore.
Yeah, I appreciate that about both of you, the holistic view, because I think there's people on one end that just want to treat everything with a medication, and some people that say, like, I'll do everything except a medication. And really, there's that happy balance for.
There is. Everyone's different.
Next question. If there is a family history of heart disease that caused a stroke in a parent, what is the earliest age someone should seek out these tests with a cardiologist?
So a majority of these tests could be starting at the age of 30. They recommend everybody by the age of 30 at least have a cholesterol panel done. And I would argue that if you're going to be having a cholesterol panel done, you should also check the lipoproteins, ApoB and Lp(a). That would be the bare minimum. The coronary calcium score that early is probably not going to be as useful, unless for some reason you did find a non-zero score, which does happen occasionally, people even at the age of 30. But particularly for that test, the CT scan we're talking about here, I would say for somebody who's at average risk or even maybe slightly higher than average risk, starting at the age of 40 for that. For people that are very high risk, it's a little bit of a different story. I don't think there's any time to start too young. They have shown in some post-mortem autopsies from people who have suffered catastrophic sudden death, like gunshot wounds and things. Even in the later teen years, this was in 17 and 18, 19-year-old children, they had significant coronary plaques already. So it is possible to start developing these things very, very early on in life, particularly if you do have those genetic risk factors, but they may just not necessarily cause all those downstream effects like heart attacks and strokes until decades later.
Thank you. Please explain C-reactive protein and the test.
C-reactive protein, I'm actually going to let you take this one.
So C-reactive protein is a non-specific inflammatory marker in the body. So many different things can increase C-reactive protein, musculoskeletal injuries, for example. But when we use a high sensitivity cardiac C-reactive protein, what we're looking for is blood vessel inflammation. So how inflamed are your blood vessels is going to tell us what your risk is for having one of those plaques break off and rupture. So if your C-reactive protein is really elevated, that tells us you could be on the precipice of having a cardiac event. It would make us do more testing sooner and be more aggressive in our interventions versus if you had a normal C-reactive protein. Most of the lab tests that we order are triangulating factors. We don't interpret anything in a vacuum. So when we're looking at your cholesterol, your ApoB, your Lp(a), physically how you're doing, your BMI, your other comorbid conditions, if you have a high C-reactive protein on top of that, it will make us push you harder towards some of these interventions.
And the other thing, just to layer onto that as well, I mean, the real-time research is changing very rapidly with respect to some of these tests, particularly the high sensitivity C-reactive protein. And within the last couple of years, the guidelines have actually changed, where previously we weren't even necessarily checking this, even in people who had heart disease, let alone treating it. There's actually a treatment recommended now using this very special anti-inflammatory drug called colchicine if your level is elevated. So it is an important marker to check, and it is one of the ones that we absolutely recommend in everybody who has known coronary disease. But if you have the capacity to be able to do it outside of that, it's a good idea to know what your level is.
I have to tell you, I'm wearing a fitness watch and it's telling me that I'm stressed right now.
Just a little lighthearted conversation.
Yeah. No, it's good. I mean, it's good to know all this. I know it can be scary and overwhelming, but I think it's important to know what to do. Okay, the next question. Where in the mainline health system can one take the suggested test? Do you simply ask your primary care physician to prescribe them?
It could be as simple as that, yeah. We as primary care doctors prescribe them for our patients. So the primary care docs absolutely have the capacity to be able to do this. There may be varying comfort levels, though, in ordering the test because of the interpretation of the results. So they may choose to refer you to a cardiologist. But in terms of ordering the test, any doctor would be capable of doing that for you.
And I would say that all of the mainline hospitals will do this test. Paoli, Bryn Mawr, Lankenau, Riddle Hospital are all capable of doing these tests. I'm not certain about the outpatient imaging centers. You might have to go to one of the hospital imaging centers to have the coronary calcium score or the coronary angiography.
Thank you. If there are many small particles, is specific cholesterol Rx rather than if many large particles? I don't know if that makes sense to you. If not, I can ask for clarification.
I think I'll give it a shot. I think maybe what we're getting at is just kind of understanding that you have all these particles, and the number of particles matters more than anything. It doesn't necessarily matter what the gross LDL cholesterol number is, which may just represent large particles of a bad type, but very few of them. It's really getting to the crux of knowing if you have a lot of those bad particles, which is where we use the apolipoprotein B as our proxy to understand that. The higher the apolipoprotein B, the more bad particles you've got. So we want to get that number as low as possible.
Thank you. The next question, there are conflicting studies about the efficacy of daily aspirin. What are your thoughts on daily aspirin?
So this has gone back and forth over the last 20 years. When I was first starting my training, it was thought that aspirin should be ubiquitously used. We should maybe even contemplate putting it in the drinking water. And then that went out of favor, I would say, over the last 10 or 15 years, where we realized that aspirin, even though it did stand to benefit some people in terms of its use for the general population, maybe had more risk than benefit. So everything kind of swung away from that. Now, within about the last 12 to 18 months, they are recognizing that not for everybody, but for maybe a larger group of people, there would be a benefit to maybe reinstituting a baby aspirin daily. And what we're really getting at is people who are very low risk or low risk don't need it. But for people that either have a family history or have other things that predispose them to developing these plaques like high cholesterol or diabetes, high blood pressure, those people, for purposes of what we refer to as primary prevention or trying to prevent the heart disease from happening, would probably stand to benefit from a baby aspirin daily. And then certainly anybody who has known coronary plaques would absolutely benefit.
I got a few private messages of people wondering if they were interested in your rates or signing up. What would be the best way to do that? Just to visit the website?
Oh, yes. The number here as well. That would come right to Dan, and I would be happy to get back in touch with you.
Okay.
And even if you just like to talk about a practice and get some more information, we're happy to do that.
Yeah, so you could either email us. If you go to our website, you can fill out we have an intake form, or that phone number, the 610-486-5980. You can text us your name and we can coordinate a time to actually talk on the phone and see how our practice could help you.
Okay, great. And what I'll do too for everybody watching is with the recording, I'll also put their contact information there as well. So you'll get an email with that. And you can also reach out to me or your care coordinator if you lost that information. Well, it looks like we answered all the questions. So thank you. I really appreciate you making the time for us today. And thank you for being here.
It's
been a pleasure.
Really
we appreciate you having us.
Thank you. Have a good day.
You too. Bye-bye.
Bye.